the President, Secretary, and the entire executive of Chandigarh Ophthalmological Society, it is my privilege to invite you all to this webinar on the Sunday morning titled Recent Updates on Neovascular AMD. I would also like to take this opportunity on behalf of COS to welcome our eminent set of experts and speakers today. Professor Vishali Gupta, whom we all know, would be chairing the session. Dr. Anirudh Agarwal will be moderating and introducing the speakers. Our esteemed panelists include Professor Mangat Dogra, Dr. Nishikant Borse, Dr. Aditya Sudhalkar, Dr. Mohit Dogra. I think Dr. Mohit Dogra has not been able to join today. And our eminent speakers also include Dr. Ale Banker, Dr. Reema Bansal, and Dr. Pradeep Kumar. I hope that the vast experience of all our experts today will surely enrich us all. I now request Dr. Anirudh Agarwal to start the proceedings of this webinar. Dr. Anirudh, please.
Good morning, everyone. A warm welcome to our webinar. So we'll directly start with the first talk of the session by Dr. Vishali Gupta. Dr. Gupta is an internationally acclaimed vitreoretina surgeon and uveitis specialist, and currently a professor and head of retina services at PGI Chandigarh. She is also the General Secretary of the IUSG and the past scientific chair of VRSI, and currently serving as the President of the Uveitis Society of India. Ma'am has also published over 250 manuscripts in peer-reviewed literature and will be speaking on the story of fluid in AMD. So I'm going to stop sharing and over to you, ma'am.
Thank you very much, and thank you, COS, for giving us the opportunity to talk about retina on a Sunday morning. You know, not an easy thing. Anyways, my topic is about the story of fluid in neovascular AMD. Now, you know, we all know that we look at the fluid and we start injecting, and it's kind of become a very automated reflex that you see fluid, you inject. But if we look back, how did this fluid come into business? If we look at the major trials which have happened in neovascular AMD over a period of time, starting with the CAT trial and going up to the rival, all the trials, when they started treating, they realized that any fluid on OCT in PRN or in treat and extend was important, because that is what when you decide to re-inject. It started long time ago with time domain OCT, even with low resolution, any fluid we were injecting, and then going on to the spectral domain OCT with the bigger trials and the more recent trials actually, HARRIER, HARRIER, COS, they all look at the fluid. Not only the trial, the various societies, EURetina, American Academy, they all recommend that it is always the OCT now, not the fluorescein, not the ICG, it's the OCT, and you look at the fluid on OCT and you decide whether the patient needs injection or not. So the fluid has become a very important practical aspect of assessing the disease activity, in other words. What is the relevance? Fluid is important in making the diagnosing, in deciding time to treatment, in treat and extend, or in PRN, about treatment interval. And what I'm going to highlight is that if you look at the fluid, it's also going to predict or help you predict the visual outcome. There are actually three types of fluid that we see in AMD, in neovascular AMD. The first one here is this fluid. This is the fluid which is under the retina and the RPE. Somehow, you will see that we don't pay much attention to fluid under the RPE, and that's a mistake, because this is where the whole disease is. The neovascular membrane is actually, this is the site. So this may be early sign of the active disease and should not be ignored. Then you see the fluid here, which is number 2. That is the subretinal compartment because that is where the choriocapillaries are proliferating. And finally, number 3 is the fluid where the fluid is intraretinal fluid. Now, this is the fluid that causes neurosensory functional deficiency associated with cystic degeneration of retina and subsequent visual loss. So if you see the intraretinal fluid, the chances of visual loss at presentation are more. So this is the sequence of event, but if you look in the practical life, all the retinal fluid, whichever compartment you are seeing, is considered the disease state and needs to be controlled with the treatment strategies. Now let's start with intraretinal fluid, that is the number 3 fluid, because I said that was the bad guy here. So this fluid can form intraretinal cyst. So if you are seeing this fluid, the cyst here at the baseline when patient comes, it kind of is going to tell you that the visual outcome is going to be poorer. If it's not present at the baseline but comes somewhere later, or it is persisting despite the treatment, again, it means bad news. The visual outcome is not going to be so good. So now let's look at what trials have said about intraretinal fluid. The post hoc analysis of view 1 and 2 indicate that presence of intraretinal fluid at baseline is a bad news because it means the visual acuity is not going to be so good. Secondary analysis of the CAT study indicates that persistent intraretinal fluid is associated with poor visual outcome during anti-VEGF therapy. Post hoc analysis of EXCITE indicates that new intraretinal cysts early after the loading have been associated with subsequent visual acuity decline. So if the cysts are not there, they have responded and the new cyst appear, even that is a bad news. So intraretinal fluid we saw is a bad news, a bad guy. Now comes the second category of the fluid, which is a subretinal fluid. Now this is the fluid which is a kind of a bit controversial, which is not such a bad guy actually, because many studies have shown that if you see only SRF at the baseline, and even if there is a little bit of subretinal fluid, after your injection, it is actually associated with either better or stable visual outcome. So, however, when we go to these studies, and I'm going to show you the studies, what they indicate. View study did the secondary analysis of subretinal fluid, and they reported that if there is a subretinal fluid at baseline, it honestly did not affect the initial visual acuity and had a relatively positive impact on visual outcome during anti-VEGF therapy. Secondary analysis of CAT study indicated that if the SRF was persistent, it did not adversely affect the visual outcome during anti-VEGF treatment. Ancillary study of EXCITE indicated that even if SRF keeps on coming back and again, that will not be a good sign. Now here comes a bit of a twist in the story. If SRF is present at baseline, good visual prognosis, even if little bit of remains during the treatment, it's fine. But if it keeps coming back again and again, it will cause poorer visual outcome. There was a very interesting study, that is the fluid study, which studied the effect of tolerance of some subretinal fluid. So what they did, they dried up first 3 injections, and then there were 2 groups. If the SRF was totally, had to be totally dried up, that was called intensive arm. But on the other hand, they had a relaxed arm. Relaxed arm means that if the SRF was around 200, up to 200, they would tolerate, they would not inject more. So we had two groups, whether you want to bone dry it or you are tolerating a little bit of SRF. And this study reported no significant difference between the intensive group and the relaxed group for mean change in baseline visual acuity from baseline till 24 months. So this study actually indicated that if you have SRF, which is little bit persistent, it is not coming back, it's not recurrent, it's not increasing, probably you can tolerate it. You don't have to chase the patients to make it bone dry because this much subretinal fluid will be tolerated and doesn't affect the visual acuity worsely. Just to show you an example of a patient, now you can see this is a patient with AMD, and this is a presentation. You mostly have subretinal fluid here. So as per our whatever we have read so far, it should have a good visual prognosis. So this is how it happens. This is 3 monthly doses have been given. It's dry. So you are not doing anything, just following it up, and 9 months also, it's not come back. So this is the kind of a better visual outcome kind of a status. However, if we go back to the fluid study, there is unresolved SRF, which, if allowed, more than 200 micrometer of SRF, which is allowed to be there for a very long time, that sometimes causes development of intraretinal fluid. So intraretinal fluid, we already learned, was a bad guy. So what happens is subretinal fluid on its own may be tolerated, but if it is coming back again and again, if it is increasing, so then it itself can cause the development of intraretinal fluid, which is a bad news. Now coming to the third category of the fluid, which is the sub-RPE fluid. Now here we would say not many studies have actually paid attention to sub-RPE fluid, and not many studies have measured the length of the pigment detachment and all. However, whatever data is available that suggests that changes in the sub-RPE space could be an early indicator of active recurrent disease, because as I mentioned previously, this is the site where the disease is actually beginning. Post-hoc analysis of view 1 and 2 studied the effect of baseline pigment epithelial detachment on visual acuity, and they reported that presence of PED at the baseline had very little impact on initial visual acuity or visual outcomes during the anti-VEGF therapy. So you really don't have to, according to them, worry much about PED. Secondary analysis of CAT study again said the same thing, that sub-RPE fluid did not impact the visual outcome during anti-VEGF treatment. However, the real life, some retrospective studies indicated that PED is associated with poor visual improvement in neovascular AMD in real-world setting. Another retrospective study indicated that early changes in the sub-RPE space are actually indicative that there is going to be recurrence, and if you want to nip the evil in the bud, so you got to pay attention to it and you cannot really ignore it. I'll show you 2 case examples to just illustrate what we mean by this. Now, this is a patient, honestly, on fundus, you don't see much happening, but when you look at it, mostly the action is happening beneath the pigment epithelial detachment. So if you are treating this patient, what you have to monitor is the height of the PED. So following injection, this is what you can see. This is before, and reduction in the height of the PED. Increasing height of the PED itself will be a very early indicator that disease is coming back. Another example, this is type 1 CNV, very clear, shown on ICG fluorescein. And when we look here, there was mostly subretinal fluid. The prognosis would have been very good, and vision was also good at baseline 6-9. And that is what we learned, that subretinal fluid, is a good thing to respond. And you give 3 injections, responded. But there was this little streak of fluid beneath the PED. Now, is it important? Is it not important? But the thing is, even if it's there, you should be monitoring this patient very closely, even if you are not injecting. Now, our patient had good visual acuity and was lost to follow-up. And let's see what happens. When he comes back 14 months later, there is that fluid under the RPE, which is definitely increased, and there is subretinal fluid, and there is that bad guy intraretinal fluid. So from that little streak which was persistent, the membrane has now gone on to full. So the vision is not 6-9 now. The vision has definitely gone down, and we are injecting. But even after 6 injections, the response is not as good as it would have been had we dealt with it at the earliest. So this is the story of the fluid that continues to evolve, which means any fluid anywhere. That indicates the disease is active. The resolution of fluid is important because that correlates to visual benefit. The magnitude, however, may vary. And the more stable CST means better disease control, which means better visual outcome. And of course, you are going to hear Nishikant talking about HARRIER and HARRIER and all those studies, where you would realize how important it is to take care of the fluid. Thank you very much for your patient hearing, and that's all from my side.
Thank you, ma'am. That was really a great talk. We have just a couple of minutes for 2 questions. So if any of the other speakers have any other question, you can ask. Meanwhile, I'd like to ask, ma'am, you've very rightly pointed out the bad guy, the intraretinal fluid. So if you were to summarize, ma'am, the localization of fluid in various spaces of the retina, how would you sort of, in the order of good to bad, how would you place the fluid in different compartments?
I think sub-RP fluid is good in the sense, not that it's good, but it indicates the very early form of the disease. The disease where the neurosensory retina is not yet affected. And now with NGOCT, we have the opportunity to look for the neovascular complex and treat it. So subretinal fluid should not be ignored, and contrary to the very early studies like CAT and all, where they did not pay much attention to PED, I think this needs to be paid attention, and it should be managed at the earliest. Subretinal fluid, only subretinal fluid is a good sign. And though most of the studies say subretinal fluid is associated with better visual acuity, but I think that is because it's only the healthy RPE which can produce fluid. And it's good because it's not totally dried up or atrophied. So if you are seeing little bit of the fluid, the vision is good because it's not totally undergone atrophy. It's indicative of healthy RPE. So if my patient, say, has a vision of 6-9 and 150 micron of fluid, I will not really keep on chasing and making it dry, but I will keep it under observation, maybe with Octa or without Octa, if somebody doesn't have, to see how this fluid is progressing. If this is progressing, we may inject. If it's not, we may just hold on. Intraretinal fluid means you have allowed the disease to be there for quite some time, and already the neurosensory retina is this. So if you're seeing patient at that point of time, you do have to treat aggressively, but again, the visual prognosis may not be as good.
Thank you, ma'am. Any other comment, Dr. Dogra sir, would you like to?
I congratulate Dr. Vishali for a very nice talk and clarifying all the things so well. One of the things which I would like to say about especially the sub-RPE fluid, I think we still go back to that avascular and vascular PED business even before OCT came in. I think most of the time we are not treating all all sub-RPE fluid. So many of these, which like they're like a PED, even a larger one, and we don't find on Octa any neovascularization, they are not treated. And it is only once they develop neovascularization, even if they are, we have seen this evolution even in cases. I have quite a few examples of these PCV cases where from a small PED, it keeps on growing over a year and for many years, and nothing happens. The vision is 6/6, so you don't tend to treat them. So is I think sub-RP, what you talked about, the subretinal fluid. I think very nicely you presented the data. I think it will be always, even if we have a fluid study or other studies, if it is progressing, the fluid is increasing in the subretinal space, maybe I think we tend to treat then. Otherwise, we also know that this kind of a fluid we see in so many other diseases where it stays there for quite some time. It doesn't damage the retina. So I think you have done a wonderful job there. And intraretinal, of course, I think you mentioned very rightly, that is the major culprit. We can't let it be there. So these are some of the things which I thought I'll just
Thank you.
mention. Yeah.
Thank you, sir. So we'll just move on, and I'll be sharing my screen. I'll go next, and I'm going to speak about the role of anti-VEGF in pachychoroid disease. So just taking a minute for this. Yes. So at the outset, I would like to thank the Chandigarh Ophthalmic Society for this honor, and Novartis for helping organize this, and Dr. Vishali ma'am for this wonderful program that she has designed. So what is pachychoroid? Pachychoroid is a group of entities which we know that have a characteristic thickened choroid, and they share an underlying common pathophysiologic mechanism whereby there is a kind of choriocapillaries compromise. And in the spectrum of pachychoroid, essentially, we'll be discussing about the pachychoroid neovasculopathy and polypoidal choroidal vasculopathy. These are two important conditions which require anti-VEGF therapy. Now, before we talk about treatment really, we need to understand that there have been several clinical trials and which have been conducted, especially in the context of PCV. And they have given us some very important learning lessons that we must understand before we even talk about treatment itself. The first thing that we must know is pachychoroid behaves differently compared to non-pachychoroid disease. Now, in the previous talk, ma'am has very elaborately explained how location of fluid plays an important role in the response to therapy and the disease progression as well. In terms of the pachychoroid versus non-pachychoroid disease, it's very important to understand that the anatomy and biologic behavior of the choroid itself are very important factors that differentiate pachychoroid from AMD, for example. So the factors which play a role are choroidal hyperpermeability, a thick choroid, of course you have polyps in PCV, and branching vascular networks. What is probably considered as outcome measures in a lot of clinical trials, and we'll talk about Everest and Planet and some of the others, they have all considered parameters such as central foveal thickness, closure rate of polyps, best corrected visual acuity. Now, so all of these may not be exactly the outcome measures that we are looking for, and that's where the challenge comes in recognizing the treatment or the correct treatments for these conditions. When we talk about the anatomy, as I said, choroidal hyperpermeability is an important factor that must be considered in patients of pachychoroid disease. And we know that this is a subjective parameter so far. We are working to automate it and quantify the choroidal hyperpermeability in our patients. But we do understand that most of the clinical trials have defined choroidal hyperpermeability as multifocal areas of hyperfluorescence with blurring of the margins. So there is a comparison here on the panel on the top shows you a patient with choroidal hyperpermeability on the ICG. The vessels show these kind of fuzziness and leakage, whereas a patient below does not show such a kind of a fuzziness of the choroidal vasculature. It's important to understand that thickness of the choroid, especially under the intraretinal fluid or even under the pigment epithelial detachment, are significant features of pachychoroid disease, and they guide the management of these patients and how we'll come to. And at this point, I think it's important for us to understand the two important clinical trials that have happened in terms of the pachychoroid disease, specifically the PCV, Everest and Planet. And these are the two landmark clinical trials. The Everest was the first randomized trial which actually compared the combination therapy of standard PDT with ranibizumab and ranibizumab monotherapy. And the criticism of Everest 1 was that it's a short-term study, and now we have the long-term Everest 2 results, which are a 24-month phase 4 study, and they have evaluated again these two treatment arms, 1:1 randomization in 322 patients. And we have two arms. It's a very simple study design compared to the Planet study. So here you have one arm, which is standard PDT with ranibizumab and of course ranibizumab monotherapy. In this study, the combination therapy fared much better in terms of the change in the best corrected visual acuity, as well as the resolution of the central foveal thickness and polyp size. Now, at the time of Everest 1 and 2, and also in Planet and several other studies, regression of the polyps has been given a lot of importance. And the regression of polyps on ICG, as well as now you have these findings on OCT, are given significant relevance. And it is said that if you have a polyp regression, it probably means that the disease is now inactive. The question is, does polyp regression really help in the disease process? So overall, the Everest has shown that combination therapy will also reduce the number of ranibizumab injections required in the treatment. So let's leave Everest to one side at this point and talk about the Planet study, which is definitely much more complicated study design. So in brief, the Planet study design was that you have three initial injections, and you have aflibercept, which is the agent which has been used, and you have 1:1 randomization. After the three injections have been given to the patients were given rescue PDT in one arm and sham PDT in the other. So there's a difference, a very basic difference from the Everest here, is that the use of PDT was really as a rescue therapy. So when you talk about comparison of Everest and Planet, you can't really compare the use of PDT in both these studies because they've been done for different indications. For example, standard full fluence PDT versus a rescue PDT. However, moving on, in the Planet study, it was shown that in both the arms, there is not really much clinical difference in the sense addition of PDT therapy or rescue PDT was non-inferior. It was not superior to monotherapy with aflibercept. So this comes us to the next question, which is comparison of Everest 2 and Planet. And we must understand that both these studies are very different from each other. The agent itself is different. You have you have aflibercept in one study and ranibizumab in the other. And there are inherent differences in the response to the PD with aflibercept and ranibizumab itself. Of course, as I said, the use of PDT was different, and you have different proportion of patients with predominantly classic CNV in both the study groups. So you can't really compare, but what you can conclude is this sort of a flow chart which I have designed, and this is taking into account several clinical trials. So I don't have a reference for this, but what we've gathered from these clinical trials is that if you have an active subfoveal or juxtafoveal PCV lesion, your initial treatment can be 4 options, and you can choose any of these 4 options. And we would like to go with monotherapy. Then aflibercept as of now would be probably the best because of the response and the study results from the Planet. However, the cost constraints are an important factor here, and so probably you can add PDT, and we generally now go for half fluence PDT, either a prompt or it could be deferred, or you can use it as a rescue therapy in patients with suboptimal response. Now we have several patients in PGI, and we are using either aflibercept monotherapy if patients can afford, or even ranibizumab for that matter. And we do have a select cohort of patients who have suboptimal response, who tend to develop hemorrhages, or who have a very thick choroid and poor response, and they might require PDT therapy. Option 2 is ranibizumab monotherapy, but again, the Everest has not shown great results with ranibizumab, so you can have the option of adding PDT. The third option, of course, is combination therapy. And we know that several retina specialists would like to do initial PDT followed by anti-VEGF or vice versa. And they use a combination therapy, and that's another very good option for patients with PCV. You, of course, have newer agents coming up. Brolucizumab is coming up. We don't have much data except in the HAWK and HARRIER. I'm told that there is a Japanese cohort of patients with pachychoroid, but we don't have a very definitive subgroup analysis, and I'm waiting for pachychoroid disease to be treated with brolucizumab and a major publication on that. And finally, we must understand that what is relevant and probably what is not relevant. In pachychoroid, BVN is actually very relevant. Presence of BVN guides your recurrence of the disease. And so your polyp size and regression may not be the only parameters that you want to assess when it comes to the response to therapy. Detailed PED structure. For example, there was a lot of discussion on multi-layered PED. But it turns out that some of these detailed or finer structures of PED may not be actually relevant when it comes to the management of these patients. So what's important is branching vascular network and other parameters. So I'd just like to conclude by saying, how do you treat? You treat, definitely anti-VEGF has a role in pachychoroid neovasculopathy. PDT may help in suboptimal response. Again, it has a lot of adverse effects, which is why we are a little scared of using PDT. To do with the choriocapillaries atrophy and secondary complications. PDT, however, can reduce your anti-VEGF burden, and it may work in thick choroid. There is a paucity of data on newer agents, and we'd like to see more data on that. And anti-VEGF monotherapy may be initiated in cases where you have significant hemorrhage, masking the underlying lesion, or if you have a peripapillary PCV. So thank you very much. Thank you once again to COS and the organizers for this wonderful meeting. So if there are any questions, I'd like to take at this point. Thank you. Sir, if you have any comments.
So Anirudh, now we really are not getting the PDT dye so easily, and neither the laser. So where does that leave us? I think it leaves us only with the anti-VEGF. So what are your comments about that?
Yes, actually, even we don't have PDT in PGI right now. And I think there is a lot of practical difficulty in organizing PDT. And so in most of our patients, we are following monotherapy, and affordability is one important factor which comes into consideration. So we treat with practically any anti-VEGF that is available for the patient. We do have, as I said, a select group of patients who would require PDT. And so these patients, we ultimately have to sort of counsel them that they can either go ahead and get a PDT elsewhere, or they continue with monotherapy, hoping that at some point some injection works. What we've also seen, we know that aflibercept is superior and sort of seems to work better, but in our experience, sometimes even switching an anti-VEGF agent from one to another, like for example, ranibizumab may work in a patient in whom aflibercept has suboptimal response. So I think that's where we are right now. So are there any other comments from anyone? We can go to the next talk by Dr. Ale Banker. So before that, I'm just going to
I think there is a suggestion from Ale in the chat box for the continuity. If Nishikant could speak before, I don't know how you take it. Anirudh, just look at that.
Yes. No, that would be fine. If Dr. Nishikant sir, are you ready with your presentation? Should we go with your presentation?
Yeah, I'm very much ready. So you want me to start my presentation on this? Okay.
Sure. I'll just take one moment to share the screen.
Okay, you want to share it? All right. Yeah.
Yes, sir. So for the sake of continuity, we are moving on and going ahead with Dr. Nishikant Borse, sir. Thank you very much for joining us. Sir is Director at the Eye Clinic and Senior Consultant at Dr. Hiranandani Hospital in Mumbai. And sir has done his fellowship from Shankar Netralaya in retina and vitreous. And his areas of interest are retinal vascular occlusions. And we all know his surgeries for vitrectomy in CRAO and diabetic retinopathy. And sir has also won awards at the Red Buckler for the ASRS. So with this, sir, if you can please share your slides.
Yeah, thank you, Anirudh, and thank you to the Chandigarh Ophthalmic Society and Novartis for arranging this wonderful webinar on a Sunday morning. So I'll be talking about the new kid on the block. I'm so sorry. Okay, let me just go back and might have to just see my whole presentation there. Okay. So I'll be basically saying about the new kid on the block, the HAWK and HARRIER trial, about that new molecule, the brolucizumab, and how maybe we can use it in clinical practice. So this is just the standard disclaimer. And now we know that, over the second year, most of the times we get a drop in the number of visits. And by the second year, the patients are also wary of taking a lot of injections. So we start getting a suboptimal outcome, and the vision starts dropping. And it doesn't happen only in our country, and it's a worldwide phenomenon. If you see this graph up, you can see everywhere, you can in every country over the second year, the number of visits go down. And if you ask any one of us, our basic aim would see that the unmet need is basically to reduce the number of visits and the amount of treatment burden in form of injections. If we can achieve that, then I think we can achieve a better amount of compliance and visual acuity in our cases. So how do we do that? And maybe the answer lies in RTH258. That is the fragment single chain antibody, which is called Pagenex in India and called Bevu internationally. And this small unit might just have the answer to that. Now let us see why it is so unique. Now we know that in any antibody, monoclonal antibody, we know that the Y part, and especially the tip having the high and the very heavy and the very light chain, has got the complementarity determining regions. And these CDRs are the ones that actually bind it to the VEGF molecule. So what they have done with a lot of engineering is that they're actually isolated only that particular small fragment and mounted a novel CDR on top of that, making it into the brolucizumab small chain antibody fragment. And this small molecule, which has got a very high and VEGF affinity, may have a very good high anti-VEGF activity and answer a lot of questions about what we need. Now, why so? Because the molecule is so small, it is just 26 kilodaltons. So, because of the molecule being small, we can put in a lot of molecules per dosage of injection that we give. And it can penetrate the retina much more than any other antibody just owing to its size. And because of the novel CDRs, is going to bind more. So, you're going to have an antibody which can be more in dosage, and it can penetrate into more the anti-VEGF agents, and also it has got more binding capacity. So these three things are making this molecule in a more of an advantageous position to treat the AMD, neovascular AMD cases that we have. Now, there are a lot of trials that were done on this particular molecule, and they have gone from the phase 1 to the phase 2, and now the phase 3 trials, which we are going to see, which are called as the HAWK and the HARRIER trials. Now, as we know, for getting the license in Europe and US, you need 2 parallel trials, and these were in form of HAWK and HARRIER trials that were done. And these were basically the phase 3 multicenter randomized double mass trials of the brolucizumab molecule, or the RTH258. The HAWK trial was done basically in US and few sites outside in Latin America and in Japan and Australia, whereas the HARRIER trial was mainly done in Europe excluding US, and a few sites in Asia and Russia. Now, both these sites had about 400 study sites together for studying. Now, what was the aim of this study? The first aim was basically to know how it works. And to know how it works was basically to know that it is not inferior to aflibercept. Now, this is the molecule that was being used for comparison, aflibercept, in mean change in the best visual corrected acuity when you start injecting. And up to week 48 was the primary outcome, but then it got extended to week 96 as well. And along with that, there were certain secondary endpoints. One was how much visual acuity could we improve? How was the drying up, whether there was intraretinal fluid or subretinal fluid present at baseline? How was the disease activity status when you started injecting at week 16? So like you gave a loading dose, and how did it react at week 16? And when you have a drying effect, we should know how it was the central thickness of the retina. And then whether we can keep our patients on 3 monthly, that is 12 weekly injections, and whether we can actually predict which of our patients and how much of our patients can be shifted to the 12 weekly dosing. And this 12 weekly dosing is the one that has got all of us so much excited into getting to know this molecule closely. Now, these are the usual key inclusion and exclusion criteria. Now, let's not go into the details of it. But the study design was very close to what we do in our clinical practice. So it had first 3 months of loading doses. And after that, at week 16, there was a disease activity assessment. Now, the week 16 activity assessment was more important as compared to the other 4 weekly disease activity assessments. On the week 16, they assess the disease activity as per the best corrected visual acuity. So if there is a decrease in BCVA of more than 5 letters, that was considered as a sign of disease activity. If the disease activity was decreased by more than 3 letters, but if the central retinal thickness increased by more than 75 microns as compared to the week 12, then you considered it as a disease activity at week 16. And also it left up to the investigator to decide if the disease activity was still visible up to week 12 as compared to week 16. And then you can decide whether the disease activity was there. Also, if you found any fluid, a new or worse intraretinal fluid, or was as compared to week 12, it was considered as a sign of disease activity. Now, that was week 16. But every 4 weeks after that, there was a disease activity assessment, but it was merely on basis of BCVA if it was lost more than 5. So the disease activity assessment was more important at week 16 in this. And why it was so important, we'll come to that later. Now, before that, let's see the CONSORT diagram of HAWK and HARRIER. The HAWK trial had 3 arms. It had a 3 milligram, a 6 milligram, and an aflibercept arm, whereas the HARRIER trial had only 2 arms, the 6 milligram of brolucizumab and aflibercept. Rest of it nearly remained the same. So this was the study design. So you give initial monthly loading doses, and then at week 16, like I told before, you do the disease activity assessment. And if we find any of those 5 clauses of disease activity, then the patient was shifted to a 8 weekly dose in the brolucizumab arm. If there was no disease activity assessment, they continued on 12 weekly doses. Now, the person who was put back on a 8 weekly dose was never ever shifted back to a 12 weekly dose. So once you enter into a 8 weekly dose, you are constantly on 8 weekly dose, never go back to 12 weekly. And the same amount of disease activity assessment was done at every 4 weeks. And anytime you found that there was disease activity, then that particular person was shifted to a 8 weekly dosage and not maintained on 12 weekly. So why so is so that you give the maximum benefit to the patient, and also we come to know how many of our patients we can maintain on 12 weekly dosage till the end of the study. Now, this is a similar thing of disease activity assessment in HAWK and HARRIER, and you have to mind that at every 4 weeks there was a disease activity assessment that was done. Now let us see what were the key points that we took from this study. Number one, the visual acuity. From baseline to week 96, the visual acuity improvement was comparable in the aflibercept arm as well as in the brolucizumab arm. In fact, even the 3 milligram brolucizumab did as well in the HAWK study. In the HARRIER study, like I said, there were only 6 milligrams of brolucizumab compared with aflibercept, and if you see, the visual acuity gain was similar. So the first primary endpoint objective was met, and it was that brolucizumab is not inferior to aflibercept in terms of visual acuity gains. Now, where did the difference come in? A difference came in like how many percent of your patients got more than 15 letters from baseline of BCVA, okay, at week 48. And if you see that, there's a slight superiority of the brolucizumab 6 milligram as compared to aflibercept in the HAWK trials, whereas in the HARRIER trials, both of them were comparable in terms of visual acuity gain. The main difference, however, came in when it comes to drying of the retina. So if you look at the diagram, you will understand that when you're using the brolucizumab, you can see that the central macular thickness is sort of like a flat curve as compared to the seesaw that you can see in aflibercept arm. Now, this typical seesaw we see in our day-to-day practice as to there is an increase in the central thickness and you give an injection and it drops down, and by the time the patient comes back, there is again a bounce back of the central retinal thickness. Whereas when we use the brolucizumab, you found the seesaw effect that you see was gone and it maintained more of a flat curve. Now, why did it maintain more of a flat curve? Because it had more drying capacity. The fluid dried better with brolucizumab. And we know that when the CST variability is less, it is associated with a better visual outcome. So if you have a higher central retinal thickness variability, it is worse for visual acuity outcomes. And that is not only in case of HAWK and HARRIER trials. If you see, even in CAT and I1, it showed that if there was more of a macular thickness fluctuation, we got back less amount of visual acuity gains. Now, if you see the pooled treatment and study data from HAWK and HARRIER with the sensitivity analysis, also you can see that if you have a better amount of visual acuity gain, if the fluid is dried better, and if the central retinal thickness doesn't vary much, you end up getting a better visual acuity improvement. And that's what might count in the future when we use this molecule. We also know that any amount of fluid, whether subretinal, intraretinal, PED, is a sign of activity of CNVM. So a better drying effect is equal to better visual acuity gains because it's going to inactivate the activity so much. Also, now let's come to the drying effect. Now you come to the subretinal fluid, it found that there was a better anatomical outcomes in the brolucizumab arm as compared to the aflibercept arm in both the HAWK and HARRIER study. It was nearly double in case of HARRIER trials where the subretinal fluid was dried in the brolucizumab arm as compared to the with a considerable number more of brolucizumab persons undergoing drying as compared to aflibercept. When it comes to RP fluid, you find the same thing. Find that the brolucizumab arm had a better drying as compared to aflibercept. So the fewer patient of brolucizumab had sub-RP fluid at week 16, 48, and 96 as compared to the aflibercept arm. So we know that there is a better drying with the brolucizumab as compared to the aflibercept. Now, how many of the patients continue to be on a 12-weekly dosage? Now, over 50% of brolucizumab 6 milligram patients, they maintained on Q12 dosing up to week 48. So we know that it's very exciting that half of our patients can be actually shifted to a 3-monthly dosing interval, and that will be more in terms of compliance and in reducing the treatment burden for our patients. Now, can we predict that how many patients will go ahead and maintain on this 3-monthly dosing. So if your patient completed the first Q12 interval, then it remained on Q12 interval up to week 48 in about 80% of the patients. So your first disease activity assessment and shifting to the Q12 is very important. So if the patient maintains on first Q12, then 80% of them can continue maintaining on Q12 up to week 48. And 75% of the people who complete this week 48 will remain up to the second year end, up to week 96 on Q12. So we can see that a lot of patients will maintain on Q12 more than 50%, and we can actually predict that how many percent of the patients will remain on to Q12. And for that, the disease activity assessment at week 16 is very important, and completion of the first 3-monthly dose is very important, because subsequent to that, we can see that 80% of the people will continue to week 48. And once those people can complete week 48, we know that about 75% of them will be on 3-monthly dosing up to the end of the second year. So in summary, we know that brolucizumab is not inferior to aflibercept. It is good for long-term maintenance of visual acuity. It has got an enhanced disease control activity in terms of drying of the retina and taking away the subretinal and the intraretinal fluid. It gives you a better control on the central macular thickness in terms that there is not much of central retinal fluctuation, and it can help us having a extended dosage regime. Now, where did the issue came in? The issue came in with the safety. If you look, in the trial, there was not much difference in the ocular side effects that was seen in the aflibercept versus the brolucizumab arm. Even though, if you see that the intraocular inflammations that were seen were, of course, on the slightly higher side in the brolucizumab arm as compared to the aflibercept arm. So it was documented even in HAWK and HARRIER that the incidence of intraocular inflammation percentage was slightly higher in case of the HAWK and HARRIER as compared to aflibercept. But what happened is, in the post-marketing data, there were reports of occlusive vasculitis coming in certain cases. So in February 23rd, 2020, about 11 cases were told in ASRS to have occlusive vasculopathy. And by March 30th, about 21 cases came in. And this led to the formation of a safety review committee, which was established by Novartis as to find out what is the reason why such inflammations are coming in. And this SRC has been given a full autonomy, and all the details about the findings are on the website, the brolucizumab.info, where we can actually log in and see how many amounts of inflammations have occurred till due date. Like this is on October 23rd. If you see, the total visual loss out of retinal vasculitis, occlusion, and vasculitis plus occlusion is about 5.13 per 10,000 injections. And that is actually the one that has made us choose the patients more carefully when we use Pagenex. Now, when it comes to India, I was lucky that I was able to use it as the very first case when it was launched in Mumbai. So I'd like to share some of my experiences with you about using Pagenex. Now, this case was a 67-year-old male who had diminution of vision since 10 days. And on examination, his visual acuity had dropped to 6/36. And he had a large subfoveal CNVM, and there were no signs of inflammation inside the eye. And there was no vasculitis, because that is the advisory that has been given, that before you inject Pagenex, you should be sure that there is no signs of inflammation present or past in eyes, because these eyes are more prone to get intraocular inflammation with Pagenex as compared to eyes who don't have any signs of inflammation. Now, this patient was given injection Pagenex. You can see there was a CNVM with some amount of SHREM, a subretinal fluid, effect or that's coming. acuity improved to 69. No retinal fluid, there was no subretinal fluid, and there was no images, hardly any coagulation has started. But after a month, that some amount of subretinal fluid had come back, and then injection Pagenex was repeated, and
It seems we have lost the connection.
Yeah, I think we can move on.
Yes, I think, thank you, sir, for that wonderful talk. There are two questions on the chat at this point. I think there's one question for ma'am by Dr. Manjari, which is, in case you have no fluid in the retina, but you have a PED, would you change the height of the PED? Would you like to sort of flatten the PED without fluid?
Not really always. First, I would like to see is there any underlying new vessels beneath the PED, and we can do that using OCTA. So if there is new vascularization, that makes sense to treat the PED. If it is a non-neovascular PED, we know with aflibercept we can flatten it. I would discuss it with the patient, see how that PED is affecting the vision, and take multiple factors into consideration before injecting it. But monitoring the height of the PED may be in very select patients where I know that if you let the PED go, and from my past experience, it progresses into fluid and something more drastic. For that patient, I would. Otherwise, for a routine patient, I will not.
Thank you, ma'am. And one question, maybe Dr. Dogra sir or Dr. Banker can take it. Would you like to treat with any combination of steroid and anti-VEGF in any pachychoroid or non-pachychoroid disease? Would that be a consideration, sir?
I have no experience of this kind of combination treatment. Of course, we have tried giving steroids, especially Ozurdex, in some cases which were refractory. Especially, I remember a case which was a RAP case, which wouldn't, with all the anti-VEGFs, it wouldn't budge at all. I think in that case, Ozurdex was given and he would respond very well. And it was a typical case of a RAP in a elderly patient. But regarding combination, I have no experience as such. Maybe somebody Ale has experience or someone here.
Sir, I think there was a lot of discussion about this, and initially when PCV came into the limelight, there were suggestions of the use of systemic steroids along with anti-VEGFs in the PCV
lot of
disease.
all devices.
Initially, we had used IVTA and Ozurdex, as sir mentioned, in a few cases of PCV. I tend to use steroids in combination when there is a massive polyp with a large area of subretinal bleeding, and you see that it extends beyond the arcades also, and maybe it's not yet encroaching onto the macula. So maybe just to decrease the inflammatory component, you can add steroids to your anti-VEGFs.
Dr. Anirudh, if I may just
Yes, yes.
minute. So I have a case presentation on the use of steroid, and I think we have a talk coming up on that as well. But one of my cases responded very well to aflibercept with Ozurdex. And as Aloy sir said, we've been using systemic steroids for serious PEDs and PCV, and then we have even managed to publish on it. In fact, we have even used successfully systemic steroids in a patient with RP-RIP and recalcitrant fluid who wasn't responding to conventional anti-VEGF therapy, but did well with steroids. So we eventually managed to publish it as a solitary case report. But yes, we do consider this. Yeah, thank you.
So we do have a talk on steroids and CNV coming up, a talk on that, and as well as real world evidence on the use of brolucizumab by Dr. Aditya. So for now, I think we can move on, and I'm going to introduce our next speaker.
Did you all lose my presentation at what level? I really don't know.
So we lost you during your case presentation. You described your case, and at that point, I think it got disconnected.
Okay, fine. So can I just finish off my second case and then we can move on? Or would you like to just move on then?
So I think we can move on. We can probably keep it at the time of the panel discussion. Maybe if we have time, we can
Okay.
have it at that point. So now I'd like to introduce our next speaker, Dr. Alia Banker, who is a senior vitreoretinal surgeon and uveitis specialist at Ahmedabad, director of the Banker's Retina Clinic and Laser Center. He's done his fellowship at Shankar Nitralaya and also spent time at the Shili Eye Center, University of California, San Diego. And he's received several honors and awards from ASRS and the Gujarat State Ophthalmic Society. Dr. Banker will be speaking on the use of anti-VEGF in pediatric population, do's and don'ts. Over to you, sir.
Thank you, Anirudh, for the kind introduction. And I would like to thank the Chandigarh Ophthalmic Society for giving me this opportunity. And I'm very fortunate that I'll be giving this talk in front of one of my mentors for this very dear thought of mine, Dr. Dogra, and of course, Dr. Vishali, who has always been a dear friend and guide. So I've been asked to speak on anti-VEGF in pediatric population, the do's and don'ts. What I'm going to do is I'm going to talk you through my talk with very clinical examples. And as we all know, as of today, the anti-VEGF mainly for pediatric population is being used in conditions like retinopathy of prematurity, Coats disease, certain pediatric choroidal neovascular membranes, and as adjuvant therapy in retinoblastoma. However, of all these, I think it's ROP that is it's maximally used. So let's see the do's for the anti-VEGF in ROP. I mean, when should you definitely use it? It's particularly indicated in cases of a type 1 ROP. It can be used even as monotherapy. But as a word of caution, in any of these, there should only be a flat NVE. There should not be any evidence of a fibrovascular tissue or any evidence of the vitreous pulling in the neovascular tissue. I think the maximum usage as of today is in cases of aggressive posterior ROP or APROP. It's also used as salvage therapy after failure or progression of laser therapy. And recently it's used, just like in diabetics, it's also been used preoperatively before surgical intervention in stage 4 and 5 cases. I think the most important do's is whenever you use the anti-VEGF for ROP or for that matter in any pediatric population has to be used in the right indication, at the right timing, with the right technique, and with the right follow-up. And most importantly, I think the right counseling. I think this forms the most important aspect of the use of anti-VEGF in pediatric populations, because it is unlike the adults, it's not been generally approved for the use in pediatric population. And as I mentioned, now it's even used as primary therapy. What are the don'ts? Well, the don'ts, most importantly, not to be used outside the indications. Most importantly, we are still not very conversant with the safety issues of the long-term side effects of the recurrence and the complications. And you should always stick to the current guidelines and randomized control trials. So just to walk you through the do's, this is one of our first cases. If you see a case like this was a case of rush disease, as we call. And if you see the persistent unique vascular lentis, the pupil not dilating, these are the cases where the anti-VEGFs are almost indicated. And what you can do is, once you give the anti-VEGF, you can see on the right side how nicely the response is with the reduction of the neovascular tissue, dilatation of the pupil, and then you can go on and add your laser and achieve a very, very nice outcome. Second, as I mentioned, all cases with a flat neovascularization with APROP or for that matter, even type 1 ROP. And this is a very typical case where you can see these neovascular fronts but there is still no fibrovascular tissue. And these cases respond extremely well with a single injection, and they almost melt away. And you can see this melting and even the progression of the vascularization into the periphery. And these are the long-term visual photos. Again, APROP, I think it's the commonest indication now. And you can see how the severe APROP looks like and how it nicely responds. This is just 2 weeks post the injection, the plus disease and the tortuosity has gone away. And you can still see a large area of avascularity in the periphery. So the treatment is still not done, but it helps us to tide over the initial emergency. And again, the hybrid ROP, that is what Dr. Dogra's group has described. Again, if you see here, these are the whitest tissue. Now here you have to be very careful. I think you have to do a very nice indirect ophthalmoscopic examination to determine that this is not elevated. And if it's not elevated, then you will see the beautiful response that the entire whitish tissue totally melts away and causes increase in the vascularity. This, or what we call as the half zone ROP, I'm going to show you one more case. This is the vascularity seen only in the peripapillary area. These are seen in extreme premature childs, extremely low earth weight babies who have received a lot of oxygen, kind of oxygen-induced retinopathy or half-zone ROP. I mean, there's no way you're going to do a laser in this. You have to have some kind of vascularity, and this is what it has been achieved. These cases might need multiple injections or, for that matter, even multiple laser sittings before we achieve a final outcome. So this eye went on to receive 2 injections, and you can see we achieved the vascularity almost up to zone 2 anterior. And at this point, you can add in your laser, thereby decreasing the amount of the destruction. Again, the don'ts, I think we all know you don't need an anesthesia to treat ROP. You can see this, we can do it even in the NICU, even if the baby is on the ventilator, it can easily be done under just topical anesthesia. Again, the do's, I think ranibizumab is the only FDA approved drug for the purpose of ROP, but there are these other drugs, bevacizumab, eflisabet, and even biosimilars, which can be used as off-label for these purpose. Don'ts and do's, again, most important is the safety profile. And there's a very nice review article on the update of all the safety profile factors. I'm not going into the details, but I think the most important aspect when you treat any pediatric cases is don't think that after giving the baby, you let the baby go away. I think you have to have the baby under your care for a prolonged period of time, maybe more than 1 to 5 years, for the evidence of any of these systemic adverse events, namely the neurodevelopmental delays or respiratory, liver, nephropathy, and all these side effects, and of course the local side effects. I think the most important aspect is to recognize the recurrence after the anti-VEGF injection. And there have been different definitions. And I think the most important definition is the progression of the disease despite the previous treatment or a reappearance of the neovascularization. And I think the use of fluorescein angiography after the anti-VEGFs in ROP is becoming extremely useful to judge whether these babies need repeat treatments, either in form of a repeat injection or a repeat laser treatment. And these are the examples, and you can see, you can do the wide field angiography, which shows you the leakage at the edges of the vascular and avascular retina. And then there is a different appearance, which gives a budding effect with peripheral avascular area. You don't see any leakage, but these can give rise to potential retinal detachment in adulthood. It's almost like you convert the APROP into FEVR stage 1 or stage 2. And currently there's a lot of interest in the use of AI to develop algorithms to identify which babies are at a higher risk of developing problems following anti-VEGFs in ROP. We in our clinic, it's compulsory and it's a must do that we follow all our babies on a long-term basis to study the structural changes by doing OSTs. We also do their vitreomacular interface studies by doing ultrasound. And what incidentally we have found that if you see a localized PVD developing at the edge of vascular and avascular retina, these babies do extremely well and almost have complete vascularization right up to the aura. But if you see the babies like this, which still have attachments, these are high-risk babies which might end up in detachments. And these babies definitely need laser and definitely need very close follow-ups. We also study the choroid by doing the EDI. And I think as for all ROP babies, no baby treated whether by laser or ROP should be left alone. You should have a long-term follow-up for their refractive errors and their strabismus also. We all know we've been doing visual field studies also to establish that the peripheral visual field loss is slightly greater in eyes who receive laser than the eyes who receive only anti-VEGF. This was the baby that I showed you, and you can see the baby only has a minimal central vision with total peripheral visual loss. And as compared to this, the baby with the flat neovascularization, which received only anti-VEGF without any additional laser. You can see the white field angiography showing a very small area of non-perfusion. We've opted not to treat, and you can see the visual fields are pretty well preserved. So currently my strategy is to use primary therapy in APROP or even half zone disease with flat neovascularization, but we vigorously follow up until the vascularity is up till zone 2A. And then we decide, do an angiography and add laser if we find any of the risk factors. I think the use of anti-VEGFs is pertinent in today's scenario, particularly in the COVID era. And this was one of the earliest cases that we treated in April during the lockdowns. And you can see there's hardly any vascularity, the very severe, almost half zone ROP. And following one injection, you can see these serial photographs, and you can see now the vascularity is very nicely developed, and you can see a faint ridge in the zone 2 anterior. And then we went on to give laser after 4 months when the lockdown actually opened up. So again, this is a very potential use in certain diseases. The don'ts, these are the cases where you should not use anti-VEGFs. You can see this case of APROP, but there is beginning of a fibrovascular traction. And this was a baby which was treated elsewhere and landed up with stage 4A with the peripheral detachment. Again, another case, you can see a severe disease, posterior disease with a thick fibrovascular tissue. Patient went on to receive injection elsewhere, and we had to add on laser because now he was developing traction in the periphery. So these are the cases where you should not use. Again, this was one of the cases which was referred to be. This was on presentation. The patient had received injection in a very peripheral center. Actually, the baby was not able to come to the city. And this was unfortunately the post-treatment developed a severe retinal detachment. In spite of us adding laser, we've added laser and now we're waiting for the surgery. Again, another case, you can see the peripheral fibrovascular tissue, which went on to develop severe vitreous hemorrhage and peripheral traction. So these are absolute don'ts. A few other indications in pediatric population, I think COS disease, it's a very useful adjuvant therapy to reduce the exudation and the VEGF proportion. And if you see this case, which was given 2 or 3 injections and combined with the peripheral laser, gave us a good result with a decrease in the amount of exudation. This is a patient in waiting. We've already given the anti-VEGF injection and now is scheduled for the peripheral laser. We've had the opportunity to treat this very young girl who developed CNV from choroidal osteoma and has responded very well to a single injection of an anti-VEGF with complete disappearance of the CNV from the osteoma. So just a brief presentation from myself on a few indications, and I would like to thank the Chandigarh Ophthalmic Society again for giving me this opportunity. Thank you very much.
Thank you, sir. For the lack of time, I think we'll just take one question for sir. In the context of ROP, and this question is by Dr. Diksha. So in your experience, how many multiple injections would you consider? What would be your maximum number of injections that you would consider?
Till now, I've given just 2 in any case, and I've stopped at 2. I've not given more than 2 injections. And after that, either add more laser or straight away go into surgery. And I forgot to mention that currently there has been a lot of interest in doing a primary vitreoretinal surgery in very severe cases of APROP. And they've found very encouraging results. Particularly certain groups are very proactive in doing primary vitrectomy. And what they feel is by depulping the vitreous, you reduce the chances of the vitreoretinal neovascularization.
Okay. So any comment from Dr. Dogra, sir?
I congratulate Ale for a very nice talk. He has maximum experience as far as giving anti-VEGF in ROP in our country, and he was the first to start. And what I think I would like to just add a little thing here what over this is, I think we have to be very careful with the follow-up. Once we have given anti-VEGF, I think we are there to follow this child, not like laser. Laser, it's like a finite treatment. Once you have done that, it has totally regressed. You may call after 6 months, you'll be fine, but not here. You need to call very frequently because they have both the problems. They can have a recurrence of the disease. And if the recurrence happens, sometimes it can be very, very fast and it might progress. He has shown some cases. That's very important. And another thing is, even up to 5 years now, the cases are reported where the vessels are still not growing and the recurrence can happen. So I think at times, if it is in zone 2, be very careful. If you have an angiography facility, you can do an angiography. If it is in zone 2 and beyond that it is avascular, I think it is better to do laser even in later stages. That is what I would like to mention. Otherwise, we can't follow these big babies. You need a general anesthesia. So it becomes a difficult situation. You can't take every time for general anesthesia. And another indication, pediatric, which I would like to mention, we have given in many, and we have some of these are the fever cases. They develop neovascularization very fast. They develop neovascularization iris. Many of them, they just depend on injection subsequently, and they do very well. So just thank you very much.
Thank you, sir. So with this, I think we'll go to our next speaker. Our next speaker is Dr. Rima ma'am. Dr. Rima is a professor at PGI and in vitreoretina and uveitis services. Ma'am has published extensively and received several awards from AIOS and other national and international societies. She's an active member of IUSG. And today, Dr. Rima ma'am will be speaking about inflammations after anti. Over to you, ma'am.
Thank you, Anirudh. Is my screen seen?
Yes, ma'am. Your PowerPoint has not yet opened up.
Is it seen now?
I think you need to first unshare the screen and then share again. Yes. Perfect.
So, good morning, everyone. And I would like to thank the Chandigarh Ophthalmic Society for this invitation and Dr. Vishali for organizing this, making this program. So I'll be talking on the inflammation following anti-VEGF injections and update. So one of the most feared complications of intravitreal injections, regardless of whatever drug we are using, is endophthalmitis, and which may be infectious or non-infectious. And this complication has been reported in eyes that have received all kinds of anti-VEGF injections for neovascular AMD. Now, if you can look at the rates of post-injection endophthalmitis, large prospective randomized clinical trials have reported the rates varying between 0.02 to 0.1%. And if we look at two meta-analyses, which included more than 3 lakh and 4 lakh injections, out of one Out of them, one study reported a significantly higher rate for bevacizumab, 0.058% versus ranibizumab, which was 0.029%. Now, coming to the rate of infectious endophthalmitis, they're definitely low, but maybe decreasing over time also. For example, the rate of clinically suspected infectious endophthalmitis after anti-VEGF agents at a single large referral institution in the reference given below, if you look at the rate between 2005 and 2017 data, this was 0.013%. And if you look at this subgroup between the same data of the last 3 to 4 years, between 2014 and 17, the rate was much less, that is 0.0038% as compared to 0.013%. However, there were no significant differences in the rates between the 3 agents that were used in the study. These were comparable to the data calculated by the IRIS Registry of American Academy of Ophthalmology, where they reported 0.025% rate of clinically suspected infectious endophthalmitis almost 2 years ago in July. And they did not find any significant differences in the rates of endophthalmitis between the 3 anti-VEGF injections. Coming to the non-infectious inflammation, the rate is not very well known, but this is also low. And again, this non-infectious inflammation also has been reported with all the 3 agents, but this is more common with aflibercept. A prospective open-label non-randomized phase 4 clinical study of 100 eyes treated with aflibercept or ranibizumab showed that the interior chamber reaction of at least 0.5 sun grading occurred in 19% of eyes receiving aflibercept versus only 2% receiving ranibizumab. However, the vitreous reaction rate of the 2 agents was not different. Now, continuing with aflibercept, additionally, 2 major clusters of non-infectious inflammation were reported. The first cluster was shortly after the drug got FDA approval in November 2011. And the second cluster was reported by the manufacturer themselves, by Regeneron, in February 2018. And they found that certain batches of syringes were associated with inflammation. According to a letter from the Vice President of Regulatory Affairs and Pharmacovigilance, Regeneron, the base rate of inflammation associated with aflibercept averages approximately 1 to 4 cases per 10,000 injections, which is 0.025%. But during the more recent cluster, the rate increased to 8 to 12 cases per 10,000 injections among the vials packaged with the identified batches of syringes. So this was reported by the manufacturer as intraocular inflammation, and they did not distinguish between whether it was infectious or a non-infectious inflammation. Now, that is why it is important to distinguish between infectious endophthalmitis and non-infectious inflammation when we are giving these injections to the patient, because clinically it's very important because the management of the 2 entities is different. You need prompt and aggressive treatment in the form of vitreous sampling, whether it's a TAP or a vitrectomy, with intravitreal antibiotics in case of infectious endophthalmitis, whereas non-infectious inflammation would resolve spontaneously or with topical steroids and cycloplegics. So these are some of the points that we as clinicians use to differentiate between infectious and non-infectious inflammation. And the various parameters that we use are the kind of presentation of the symptoms, the pain, visual acuity, corneal edema, reaction in the interior chamber, presence of fibrin or hypopyon, reaction in the vitreous, management, and of course, prognosis. Now, this is the chart that I've taken, which just shows the rates of sterile inflammation between various anti-VEGF agents, and I've marked the lowest and the highest rates. You can see it has been shown to vary from 0 to 14.3%. Now, what is sterile endophthalmitis? This has also been referred to by some as pseudoendophthalmitis, which means any acute intraocular inflammation without infection that resolves without antibiotic treatment, unlike the true endophthalmitis. And several hypotheses pertaining to the etiology of sterile inflammation secondary to the intravitreal anti-VEGF injections have been laid. For example, when we look at intravitreal bevacizumab, what is the reason for the inflammatory response to intravitreal bevacizumab? And then we have diverse hypotheses. The intravenous bevacizumab is available as 100 milligrams per 4 ml or 400 milligrams per 16 ml. The intravitreal dose, which is 0.05 ml most commonly, it requires manipulation and risk of contamination. The bacterial endotoxins, which are frequent and recalcitrant contaminants of the antibody preparations during the production phase of the drug. Preparations of bevacizumab that are originally designed for intravenous use may contain traces of these bacterial endotoxins at levels that incite intravitreal inflammation, even though they are of no significance when this drug is given systemically. Another important fact is that the manufacturer of bevacizumab recommends to store it, to keep it refrigerated at 2 to 8 degrees Celsius and to keep it protected from light. So any temperature fluctuation has been proposed as a factor that may increase the immunogenic properties of the drug as it does to the proteins. And we know that protein degradation creates novel antigenic epitopes which are not found in the parent molecule. Adverse events with bevacizumab have also been linked to the suspected contamination, possibly arising as a consequence of vial splitting and compounding. Now, this was the first study to directly compare the incidence of severe ocular inflammation following ranibizumab and aflibercept treatment in routine clinical practice in the US. And this had the United States physician-level claims data from the integrated data warehouse, where about 80% of the practicing ophthalmologists in the US submit claims data to this database. This compared the severe ocular inflammation rates per 1,000 injections over a period of 18 months for each therapy that was given for neovascular AMD. These are the number of injections. And what they found was there was significantly more severe inflammation in aflibercept, which was 1.06 per 1,000 injections, compared to ranibizumab, which was 0.64 per 1,000 injections during routine clinical practice in patients with neovascular AMD. Now, why aflibercept mediates inflammation? The pro-inflammatory interaction of the Fc component, which is present in aflibercept, it reacts with the intraretinal Fc receptors. This is a plausible pathophysiological pathway. And in primate studies of intravitreal aflibercept and ranibizumab injections, aflibercept was primarily taken up by the neuronal and the RPE cells, unlike the ranibizumab molecule, which is smaller and permeated the retina through intercellular spaces. The putative contribution of this Fc component of aflibercept to intraretinal pro-inflammatory degeneration has been supported by recent observations of increased expression of Fc receptors in the retinas of donor eyes from patients with neovascular AMD compared to the healthy controls. As with aflibercept, this Fc component is also present in bevacizumab. So this provides a further test of the hypothesis that the inflammatory response is mediated by the Fc fragment, which is present in these molecules, which interacts with the retinal Fc receptors. And high rates of culture negative endophthalmitis following bevacizumab compared to ranibizumab are also compatible with this hypothesis. So the prophylaxis, currently the only preventive prophylaxis which is known is for post-operative infection is the application of topical povidone iodine. Evidence of efficacy of topical antibiotics is inconclusive. This retrospective cohort study of the US claims data examine the risk of developing endophthalmitis following the intravitreal injections. All the three agents were compared in patients with neovascular AMD between 2011 and 2013. And the primary outcome was occurrence of endophthalmitis within 30 days of the claim for the intravitreal injection. And out of more than 8 lakh injections from 1 lakh patients with neovascular AMD, endophthalmitis rates were 0.1% with aflibercept, decreasing with bevacizumab, which was 0.56%, further decreasing with ranibizumab, 0.07%. Now this shows that aflibercept, which is the first bar, had significantly higher endophthalmitis risk compared to ranibizumab, and the endophthalmitis risk was similar for both bevacizumab and ranibizumab. This shows the rates of endophthalmitis during the 6-month splitting period for the 18-month study. And as you can see, aflibercept is topping everywhere in terms of rates of endophthalmitis as compared to the other two drugs. So this was the median time from the date of injection to the first episode of endophthalmitis, which was 3 days in case of aflibercept and 5 days for bevacizumab and ranibizumab. Coming to the endophthalmitis aspect of the CAT trial, the incidence and outcomes of endophthalmitis were also studied in patients who were enrolled in the CAT, and endophthalmitis was reported in 11 of 18,000 injections from 11 patients. And they found that the rate of endophthalmitis was 0.15% among injections with no antibiotic use, 0.08% among injections with pre-injection antibiotics only, decreasing 0.06 among injections with post-injection antibiotics only, and further decreasing to 0.04% among injections with both pre and post-injection antibiotics. All these patients received intravitreal antibiotics and 4 underwent vitrectomy. So they found that the rates of endophthalmitis were low and similar to those in other large-scale studies. So use of topical antibiotics either before or after the injection does not seem to reduce the risk significantly. Now with the upcoming brolucizumab, we have information on inflammation related to this drug. The incidence of intraocular inflammation in HAWK and HARRIER was higher with brolucizumab at 6 milligrams, which was 4% compared to 2 milligrams of aflibercept, which was 1% in eyes that were treated for neovascular AMD. So here we had a spectrum of uncommon findings as compared to the previous agents in terms of retinal vasculitis and retinal vascular occlusions in these patients who received the drug. So there is, keeping in view for these kind of uncommon intraocular inflammation findings, there is a need for early diagnosis, prompt and timely intervention, intensive treatment, intensive observation of these patients, and frequent monitoring to minimize the risk of progression of these events. I'll not be covering this in detail because we have Aditya speaking on HAWK and HARRIER real-world experience. So this is the recent most publication on the expert opinion on management of these inflammation-related complications with brolucizumab. So coming to the Indian perspective, we had a high alert in India following a single incident of cluster endophthalmitis in eye hospital in Gujarat. Why I'm talking about is because we have a high volume of patients in India. We have a high volume usage of these drugs. So it's important to know what happened related to the inflammation of all these drugs. So in January 2016, the DCGI issued a high alert notice on the use of bevacizumab. This decision not only caused consternation among Indian ophthalmologists, but also led to a virtual ban on the drug for intraocular use. Multiple studies have shown the efficacy, the safety, and non-inferiority of the relatively inexpensive bevacizumab to the other two agents. So deliberations with the concerned authorities resulted in withdrawal of this alert in March 2016. So we had subsequent to this, we had the guidelines for intravitreal injections by the VRSI and the AIOS. And these were drafted jointly by the AIOS and VRSI along with 4-member expert committee based on a meeting that was held in February 16 between the joint DCGI, various representatives from AIOS, VRSI, and from Roche. And the guidelines say that ophthalmologists in India can use Avastin as an off-label drug for intravitreal injection. However, you need to have a proper informed consent from the patient. The injection should be performed in sterile environment, should be done by the trained ophthalmologists. And just a little bit about our experience in July 2016, we had 28 patients who developed cluster endophthalmitis after receiving intravitreal bevacizumab, out of which 6 were treated with neovascular AMD, and 12 had TAS-like reaction, and 16 had classical endophthalmitis. And these were the various clinical symptoms that the patients presented with. All of them had blurred vision. And we found the organisms Stenotrophomonas maltophilia in all samples by the MALDI and by bacterial cultures in 10 patients. So the suspected injection vials and syringes were the ones which grew this organism, and the source of the outbreak was confirmed to be the contaminated bevacizumab vial. So the most critical aspect of this is that the process of compounding, which may compromise its sterility. With no compounding pharmacies available in India for the preparation of this drug for the use by the ophthalmologist, we have the guidelines by, as I said, to minimize such events in the absence of compounding pharmacies. Another concern is immediate sequential bilateral intravitreal treatment with anti-VEGF injection. As per the AIOS guidelines, it is recommended to do the injection procedure in an OR or a sterile room designated for such procedures, taking all the precautions as are taken for any intraocular surgeries. We do not recommend intravitreal injection in an office setting. Bilateral injections are not recommended, and injection for the other eye should be planned at least 1 week later. So in an Indian scenario, the risk of bilateral endophthalmitis following the immediate sequential bilateral intravitreal injection, though small, we cannot ignore it, given the fact that many patients receiving these injections already have very good visual acuity before the injection. So it may invite medical legal problems for the practicing ophthalmologists too. So the AIOS, the recently published AIOS survey on the practice pattern of anti-VEGF injection, which was an online survey to evaluate the practice pattern of Indian retina specialists in administering the intravitreal anti-VEGF injection. The various categorizations were pre-injection patient preparation, injection aliquoting, injection administration, post-injection care, results, and the results were then compared with the similar surveys in the Europe, UK, and the US. 73% retina specialists responded in this, and these were the various figures that they found. So the conclusion of this survey was peri-procedure antibiotic use, injection in the minor OR, wearing of gloves and masks were higher than practices in other countries. Ophthalmologists in India practice asepsis in intravitreal injection procedure, but there is no uniform protocol for aliquoting bevacizumab. Single-use bevacizumab, while for exclusive ophthalmic use, would further improve the safety of the procedure. So thank you very much for this, giving me this talk. Thank you.
Thank you, ma'am. That was a very exhaustive and very learned presentation. I think it hardly leaves any scope for questions. At this point, I think I'd just like to invite Dr. Nishikant, sir, if you can take a couple of minutes. We are actually overshooting time. So if you can share your screen, and we'd like to see a couple of your cases. And then we'll move on to our further talks by Dr. Pradeep Kumar and Dr. Aditya. So are you there? We can't hear you.
I think it's better to move forward, Anirudh. It's already 1:10.
Yes, ma'am. I think in that case, we can move forward to our next
Yeah,
talk.
I think there is something wrong with my internet. So, it keeps on fluctuating today.
No problem, sir. We'll go on to our next talk then. Next talk is by Lieutenant Colonel Dr. Pradeep Kumar, who's an associate professor of ophthalmology and Command Hospital, Chandi Mandir, Panchkula. And his areas of interest also include retinal imaging, macular surgery, and pachychoroid. And over to you, sir. I'll just stop sharing my screen. Yeah. I will be speaking on corticosteroids in CNV.
A very good afternoon to all my esteemed teachers and colleagues. Firstly, I'll thank Chandigarh Ophthalmic Society and Professor Vishali Gupta for giving me this opportunity to speak here. I'll be talking about a slightly controversial topic, that is steroids in neovascular AMD. I don't have any financial ties, being a government doctor. The initial evidence started coming up as early as 2003, when we saw the interest in triamcinolone, which was being used in the rat models by Ciula et al. And they showed that CNV could be treated experimentally induced by laser and then with triamcinolone. They found later on the work of Jonas continued, who experimented with 25 and 20 milligram dose in patients with choroidal neovascular membrane. This was the era when we were mostly treating our patients with laser therapy, and this was a new thing to deal with. By 2007, we had Indian publications talking about the role of combined steroids with photodynamic therapy. And again, the agent of choice was triamcinolone acetonide. The entry of anti-VEGF changed the scenario, becoming the gold standard over a period of time. But still, we continue to see the usage of combination steroids, especially dexamethasone. And one very important study came from Bakri et al., where they used the dose of 200 microgram commercially available dexamethasone used for intravenous use in their study. I'll come to this point later in my study why it's important. By 2013, we had 1,503 publications talking about anti-angiogenesis and periocular and intraocular steroids, but the role remained unclear. And the LucidX study also failed to show any promising results. So where were we before the Ozurdex came on scene? That the role of steroids was unclear, but dexamethasone dosing was possible using a 200 microgram dose. With coming of Ozurdex implant, propelled by financial interest and also being safe as declared by FDA, people started using it in their patients of choroidal neovascular membranes. And Calvo et al. In 7 patients found that it reduced the need for reinjection. But a major study by Kupperman et al., which was a multicentric study in 123 eyes, showed that Ozurdex did, in practical world, reduce the need for ranibizumab injections. To bring out, they were using this in all kinds of neovascular AMD patients, compared to the resistant CNV, where we have limited our usage of steroids nowadays. They found that in the 75th percentile of patients, they were able to go from 56 to 85 days re-injection interval. So where all do you think we were supposed to use these steroids? The answers were provided by ORA study and Barikian et al. Though ORA study did not find a difference between ranibizumab monotherapy and combination therapy, Barikian et al. Found that in cases of resistant CNV, they defined resistance as a patient who had mandatorily received 3 bevacizumab followed by 3 ranibizumab injections and still had persistent fluid. They found that the intraretinal fluid responded, but the subretinal fluid did not. And this became the key point in managing choroidal neovascular membranes with steroid, that the intraretinal fluid responds while the subretinal responds. It has been used for resistant edema since then in multiple trials by the group of Sandra Rizzo-Riedel, who used it for 40 eyes, comparing over 12 months. They found that only the anatomical changes were improving, but the visual outcomes were not. And Todorich et al. Used it in resistant cases who had, on an average, received 26.3 injections, and again reported that there was anatomic success, which was seen more when the combined therapy was introduced early in the disease. And in patients who had already received 40-45 injections, even steroids did not help much. So why were the steroids working? Again, the group of Sandra Rizzo et al., they found out that if we took out the samples from aqueous humor at baseline and at each retreatment, in 3 study groups, they had a control group, sorry for the crowded slide, a control group, the neovascular AMD group, which was treated with monotherapy and combined therapy. All these inflammatory chemokines, they were increased compared to the control groups in both the CNV groups. On treatment with steroids, the inflammatory proteins were reducing in these CNV groups. However, clinically, there were no difference in the functional and anatomical outcome of the disease. So 2 contradictory statements from a study. Dexamethasone continues to be used. People have said in large papers that it is feasible to use it for CNV. And all the studies till now had been on resistant disease. It showed no change in visual outcome except this 2018 study of 136 eyes, which had a not so robust design of the study, where they said that after using triamcinolone 4 milligrams, there was better BCVA and OCT picture. So what does the evidence say till now? That there is a role of steroids in resistant neovascular AMD as an adjunct. It works on intraretinal fluid, not on subretinal fluid. And we have different modalities of using steroids as an implant, as 200 microgram dose, or as triamcinolone 4 milligrams. So there was a knowledge gap which we needed to answer. So was Ozurdex implant the only way of delivering steroid? The answer was no, as had been provided by previous earlier and the 2009 study of Bakri et al. We can use 0.05 ml of commercially available dexamethasone also. And what happened if we use dexamethasone in fresh cases? We did not have an answer to that. We knew that ellipsoid damage occurs more due to intraretinal fluid, so it is important to target this intraretinal fluid as early as possible. And to use it as monotherapy, well, that needs to be answered in the longer run. And the side effects need to be charted out. So I present my very short experience of 3 years being in Chandigarh. We had a retrospective analysis of patients in whom, when we felt that there was need of adjunct steroids, we compiled their data and compared them to 24 similar controls. We used the commercially available preparation, 200 microgram in 0.05 ml, along with Lucentis, and we realized that there was faster resolution of fluid, there was more complete resolution of fluid, and the re-injection interval increased. The visual outcomes did not change much still, even though I was not only using it for resistant disease, we were using it for fresh cases also. So coming to when you want to choose, this is a typical case where it's a no-brainer that you're only going to use a monotherapy. Since there is no intraretinal fluid, it's only chiefly the subretinal and the subarachnoid fluid that you are targeting. And then there were such cases where you don't even need to go to the OCT. You see this large hemorrhage clinically and you choose a monotherapy. But then come these cases where there's a middle ground. When you realize a subretinal component, there is an intraretinal component, the fluid is there. And then you have patients like this, where there are large cystic spaces intraretinally. These are the patients where we recommend that, yes, adjuvant role of dexamethasone exists. There have been other papers which talk about the anti-inflammatory therapy in choroidal neovascular membrane. One of these studies is already mentioned in the presentation. And people are now trying to redesign their approaches by using PDMS layers, which will release dexamethasone over a period of time, and using nanoparticles. Thank you.
Thank you, sir. So with this, we come to our last talk of the session. So if you can please stop sharing your screen, I'll introduce Aditya. So our next speaker is Dr. Aditya Sudhalkar. Dr. Aditya Sudhalkar is a consultant vitreoretina surgeon at Sudhalkar Eye Hospital and Retina Center, Baroda, as well as Raghudeep Eye Clinic in Ahmedabad. He has several years of experience in vitreoretinal surgery with several publications, and his areas of interest include diabetic macular edema, detachments, and he's written a book on minimal surgery for retinal detachment. So with this, Dr. Aditya, he'll be speaking on the real-world experience with brolucizumab.
Thank you so much, Dr. Anirudh, for such a kind introduction. And in the interest of time, I've shortened my talk to 2 cases each from Germany and India. And these are just pictures from our clinic in Germany. Just like to state at this point that I have full rights over whatever data that I'll be presenting from Germany. So coming to the cases, this was a 74-year-old retired physician from Bremen who presented to us with metamorphopsia since 4 days. Reading ability. So the vision in the left eye was affected, and the anterior segment examination was quite normal except for the presence of pseudophakia. Now the clinical photos, the angiography, and the OCT scans were in line with what one would expect with a type 1 CNV. Now, just to give a heads up to everyone, in Germany, the protocol is for all macular disease, you give treat and extend. That is, all patients are initiated with 6 monthly injections, either of aflibercept or ranibizumab. If it is AMD, then we necessarily have to begin with aflibercept. And regardless of the response to the first 2 or 3 injections, we complete 6 consecutive monthly injections. After that, we increase the treatment interval in 2 weekly spurts. And at any point in time, if it is felt that the fluid is recurring, you shorten the interval correspondingly by 2 weeks. Now, with the Altair study, there is an allowance for 4 weekly increases in the treatment interval. And you can extend the treatment or maintenance therapy to a maximum of 16 weeks, which would essentially mean 3 injections a year with aflibercept. So now in this patient, unfortunately, despite regular therapy, he continued to worsen. So we see increasing fluid in all compartments along with this choroidal cleft, which becomes more and more prominent at varying time points, as the disease progresses. So despite 6 consecutive injections of aflibercept and then switch overs to 6 consecutive injections of ranibizumab, he continued to worsen. So in March this year, he finally received his first brolucizumab injection. The first itself showed a significant change, not only in the fluid, but also in the reduction of this cleft. And it almost became normal. I mean, at least the exudation resolved with the second one. He received since this was not a naive patient, he just received 2 injections. We saw this recurrence at 12 weeks, following which he received his 3rd injection. And now he has been put on maintenance therapy. So for brolucizumab, the German protocol states that it is 3 consecutive injections followed by a follow-up at 8 weeks as per HARRIER and ARRIER, and then a mandatory injection at 12 weeks. The second patient I'm just going to skip because it's a routine case and there's in the interest of time. But this patient is interesting. So this was a 69-year-old Arab refugee who presented to us with metamorphosis and an inability to pray since 1 month. Her vision was obviously affected and she was phakic, so nothing significant in the anti-ACM. So the angiography and the clinical picture showed a very evident CNVM. Now here, if you see after the first injection itself, it was nothing short of a miraculous response. And the second nearly resolved the disease. Of course, we still see the evidence of CNVM here with the double A sign and everything. So she has been put on 3 consecutive injections and she has received her 4th injection as well last month. So to summarize our experience in Germany of 30 patients with a 6-month follow-up, it is even in a small setup such as ours, and a weekly count of 30 patients is not uncommon in Europe and the US. So 12 of these were treatment naive and 18 were switch patients, which was understandable given our reluctance to use the drug in naive patients from the word go. However, the next 30 patients are more or less half and half. The findings are also in line with what one would expect, but the most important is that we have had no instances of inflammation or vasculitis thus far. There have been 3 or 4 reports of TAS-like or sterile endophthalmitis in Europe, but not in Germany. Also, I would also like to say that I think out of the 12 treatment naive patients, 7 of them completed successfully the first Q12 quarter, which is considered an important landmark as per the HARRIER and ARRIER. So coming to the Indian cases, this was a 65-year-old male who presented to us with metamorphopsia in the left eye since 3 days, and he had a history of recent cataract surgery a fortnight ago. So the vision was not too bad, but the Amsler test was positive, and he had his OCT angio and FFA done elsewhere. So these are scanned images, and I apologize for the poor quality of the images, but this is what it looked like. Now, what is interesting in this patient is that the right eye also shows evidence of subclinical CNVM. So what we see here is this is the right eye OCT, and it has continued to progress, but it has never reached the fovea. So he's asymptomatic. He has not received any treatment over the 3 years of follow-up that we have had, and he has not had cataract surgery in the right eye as well. But the left eye continued to worsen despite reasonably regular therapy. So he's had about 17 Eylea injections, 7 or 8 Accentrix injections, or 3 or 4 biosimilar injections, and 2 or 3 Avastin or bevacizumab injections. But he continued to worsen, and it was a very aggressive CNVM. Now, in this case, what ultimately worked was a combination of Ozurdex and or the dexamethasone implant and aflibercept. So whatever is going on in this patient is between the fovea and the disc, but this is what worked, and you can see the implant in C2 here. But 6 weeks later, we were back to where we were. So at this point in time, we injected brolucizumab because it had become available in India. And I'll skip the interim follow-up, but this is what it looks like at nearly 6 weeks after the injection. So what we see here is the scan was done elsewhere. The patient is currently in the UK. There is obvious swelling here, but at least the center is fluid-free. There is obvious destruction of the retinal architecture as well. And for the past year, his vision has not gone beyond 660 or 636. This is just from the right eye, and what we see here is that there is evident fluid with some subretinal fluid here as well, but he's still asymptomatic, and which is why we have continued to defer treatment in this patient. This was just a follow-up at 1 week that we had for inflammation. We did a peripheral indirect examination, no evidence of inflammation or vasculitis, and we have been in constant telephonic touch with the patient throughout the course of follow-up. The second patient here, this is what he presented to us with. So he has been a regular patient of ours since 2016. So this was the primary OCT, but when he actually came back for treatment, which was about a fortnight later, he had already had a RP rib. So this obviously compromised his vision, but notwithstanding the rib, he had maintained very good vision until 2018 or 19. So just to cut a long story short, he became recalcitrant to both ranibizumab and aflibercept during the course of therapy. And at this point in time, we injected brolucizumab. Now we only have a 7-day follow-up because it's due for his follow-up next week. So we hope to have more data then. But as you can see, he has responded quite well to an injection. Even the first patient that we did, we had counseled him for steroids here. We just heard an extensive talk on that by Pradeep sir. And given the inflammatory nature of the CNVM, but this patient had apprehensions about the possible negative effects of steroids. And he knows several doctors in the US personally, Dr. K.V. Chalam being one of them in Jacksonville. So he deferred his injection to nearly 3 years, unfortunately, to his detriment. So thank you very much for your attention. Dr. Anirudh, over to you.
Thank you very much. I think that was a very interesting experience that you shared on follow-up of patients treated with different therapies and with brolucizumab. So at this point, if there are any comments from the panelists, Dr. Vishali ma'am.
No, I think there are 1 or 2 questions which you have to. There is one for Rima privately.
There's one question in the chat for Dr. Rima ma'am, which says, in these patients, when you're giving intravitreal injections, would you recommend doing anterior chamber paracentesis? And does that lead to inflammation? Do you avoid doing it?
Can't hear Rima.
Can you hear me now?
Yeah.
Yes, ma'am.
The question is, should we do it or should we not do it? Would predisposed should best be avoided. I think it's not the anterior chamber tap that is predisposing to inflammation. So if you are in the habit of doing a tap in all the patients and they are behaving all the same, it's fine. But if you happen to observe it in a patient where you've done it and where the inflammation is more, then you need to keep a watch. But if you consistently do it in all patients and you develop in only one, I don't think that should be the reason for it.
Yeah.
Thank you. I think we have a lot of evidence now coming in support of how the inflammation should be tackled with brolucizumab and how these patients should be followed up. So I think that's a very good initiative. And just Dr. Borse, since you couldn't share your slides, can you share your experience, like personal experience on how you think brolucizumab works in your patients? If you can summarize in like 1 or 2 sentences.
I think Anirudh is not able to.
Who's careful enough to respond back to us if there are any untoward effect. Like I tell them that anything out of the way, please come back and report to us. And we have to definitely investigate and examine the eye carefully for signs of any old vasculitis or any inflammation. Because as per the advisory, if you already have an existing or a pre-existing inflammation, the chances of you landing up with an intraocular inflammation is much more with brolucizumab.
Would you be, worried about using brolucizumab in a patient practically one-eyed or having only good vision in one eye as of today?
Yes, definitely. I mean, if you will use it only if you have exhausted all your other options. And as of now, till the time we get a hang of it, I think it's better to avoid that.
Yeah, I think that's an important issue. I think one-eyed patient, we can avoid altogether. And if we want to use it, maybe in a second eye, where everything else has failed, you use it to gain the initial confidence, because that is where the problem is. If we don't have a confidence in using it and we find that we might land up into a trouble with a severe occlusive vasculitis. We're talking of occlusive vasculitis, not a simple vasculitis. So I think maybe if we start that way, avoiding one-eyed patient and only the second eye of where you have exhausted most of other things and you use it, maybe your confidence building would be there and we'll have a more experience pulled in. It has to come in from, I think, everybody. Maybe VRSI or some agency has to coordinate to get then we'll get a confidence to use it. Otherwise, it seems like a very good drug, but I think this occlusive vasculitis business has really kind of put a little thing on it. So in fact, in my own center here where I work now, we did get this is already procured, but we have not had a heart to use as yet. So that is where we stand.
Now, I've used it in 3 cases with very good experience, but like I told, we have to have a very informed and a very aware patient who can come to you, because the vasculitis is after prolonged inflammation. So, if they come to you earlier, it is always better to treat the inflammation at the earliest to prevent a further vasculitis in these cases.
Besides vasculitis, there are also reports coming of arterial occlusion.
Yes.
So that is after 3rd or 4th injection because of anti-drug antibodies. So we need to look at a lot of aspects.
Absolutely. Absolutely. We need to.
So I think in the next few months, we need to build confidence on brolucizumab, as well as probably the COVID vaccination. So I think they're going to go hand in hand. So hopefully 2021 is going to bring a lot of optimism on patient outcomes with these newer agents like brolucizumab. And I think we've overshot already. Thank you once again to Chandigarh Ophthalmic Society, Dr. Vishali Gupta, for chairing this session, all the panelists, Dr. Dogra, Dr. Borse, Dr. Aditya, Dr. Banker, for joining in, our guests, and our speakers also, Dr. Reema Bansal, Dr. Pradeep Kumar, and thank you very much to Novartis for organizing this. And I'll just hand over to Dr. Vishali for her final concluding comments.
And I'm thankful to everybody, COS, Novartis, all the speakers, especially dedicating their Sunday morning to us. And I think Chintan is here on behalf of COS. She'll say the final word.
Thank you, ma'am. Thank you, Anirudh. And thank you, everyone. My apologies for not being here in the beginning. But I'm sure it must have been a very successful webinar. And I don't think I will take too much of everybody's time now, since it's already a Sunday afternoon. And special thanks to our guest speakers, Dr. Ale Banker, Dr. Nishikant, Dr. Pradeep, and of course, Professor Dogra sir, and our own faculty. Thank you, ma'am. And thank you, everyone.
Thank you, everyone.
Thank you.
Thank you.
Bye-bye.
Thank you. Thank you, Ale.
Safe, everyone.
Thanks, Nishikant.
Bye-bye. Thank you.
Bye-bye, sir. See you.
Thank you.